Hi, everybody. Good morning or afternoon, depending on where you may be joining us. My name is Matt, and I first want to say thank you so much for registering for the webinar today. We've got a great session. It is a shorter one. It's about 30 minutes, so we will get into it. A little bit about today's presenters. If this is your first Provider Trust webinar, I'll introduce you to our co-founder, Mike Rosen, who before starting Provider Trust in 2010, worked in the background screening industry for years. And he is with Donna Thiel today, our Chief Compliance Officer. And before Provider Trust, she worked for one of the nation's largest post-acute care facilities. And we just this is the dream team for compliance. So you guys have the right people on the line today. And we are talking about compliance in 2020, where to focus in the new year. So a couple notes before we get started. Our webinars are good for CEUs. This one is good for 0.6 CEUs, being a 30-minute webinar. We will also be sharing a copy of the slides as well as the recording this afternoon. The CCB will be giving us our certificate very soon, and as soon as we get that, we will forward it on to all of you. So just a little bit about that. Be on the lookout this afternoon for that email. Provider Trust, we are here in Nashville, Tennessee. We've got a lot of organizations that we partner with here in Tennessee and across the nation. I'm sure some are on the line today, but we just are passionate about healthcare compliance and working with individuals that are close to that. We also believe that a smarter healthcare makes a safer healthcare, and we do this by monitoring healthcare populations to identify compliance and credential issues before they impact patients. We're also very passionate about educating folks like you and continuing to learn and provide relevant educational resources for you all. If you have been on the site, you'll know that we have more than 400 resources, unique resources, blogs, past webinar recordings, ebooks, and everything in between for you guys to use and learn from at your leisure. We also look for feedback from you guys. So if there's something you want to learn more about, please fill that in the survey after the webinar today, and we'll either get to it in a blog or a webinar or however we see fit. So we just like to get feedback from you guys, and we are very happy to be able to share those resources with the compliance community. So a little bit about our webinars that are coming up. February 26th, we'll be talking about how honest relationships build high-performing teams. And we have our Director of People Ops on that one, who has done just a fantastic job here at Provider Trust, and will be able to give you an enormous amount of insight in how to build a great team. And then March 25th, we will be covering the future of interstate license monitoring and telehealth delivery. And then in April, we will be covering a little bit about HR, how to create margin and automate and delegate certain roles and activities to your HR team. So that's a little bit about our webinars coming up. Today's agenda, we will start, Donna will cover the continuous changes in healthcare, and then we will move into the new rules, regulations, and reimbursement, followed by patient safety standards and controls, and then we will end the presentation with managing your data and key metrics. So with that, I will pass it on to Donna Thiel.
Thanks, Matt, and Happy New Year, everyone. Our first webinar of 2020. It's hard to believe it's already almost February. The year is going very fast, as has January. We're excited to be here again with you in 2020 and look forward to some great content for all of you as the year goes on. So Mike Rosen and I just got back last night, actually, from the HCCA Managed Care Conference. And as any of you know that have been participants in any of those conferences, there's all sorts of healthcare changes that are talked about at these conferences. So we will kind of incorporate some of the information that we both learned throughout the conference as we update the presentation today. So let's talk a little bit about some of the changes. The first slide we talk about is changes in the reimbursement model. I think we all recognize that at any point in time, the role of the government or CMS, right, is oversight and monitoring, and they're always looking to try to lower costs and have more efficient processes. So that usually relates to changes in reimbursement models. And when we look from a compliance perspective, whenever there's a change in reimbursement model, there's all sorts of new risks and complexities that come into the organization. First and foremost, right, there's new billing rules, there's new ways that we have to capture documentation, the way that we're presenting the information, and that means there's education to our workforce. Some of us learn quicker than others, and how we have to change our current practices to meet those new requirements. There's new ideas within your organization of how to maximize that reimbursement model, right? Every time it changes, we know there's always some good practices that we can do to really maximize reimbursement. And when you're talking about maximizing reimbursement from a compliance perspective, we're always stepping back and saying, okay, are we doing that within the lines of the regulation and the intent of the regulations? Are we going outside of bounds? Are we pushing the boundaries a little bit too far? So certainly new complexities that we have to build into our compliance program. New ways of working. Are there new things, new communication methods that have to be put in place? Is there information that has to flow in a different way? So as we're looking at our audits and monitoring that we're doing from a compliance perspective, what do we have to change based on these new reimbursement models? And then, like I just said, for the new audits and monitoring, how, what are the roll-up reports? What are the metrics that we're being asked to put together? Oh my goodness, it is the first webinar of January. Stumbling through my words. Let's go on to the next slide and talk a little bit about CMS. We have, when we were at the conference this week, Kim Brandt, if any of you have had the opportunity to listen to Kim speak, we all know that she speaks extremely fast. I think she's very proud of that. I think she likes to see if we can all keep up with her. But she shared with us some of the initiatives that CMS has, and she talked a little bit about some of the Stark laws that Mike's going to cover in a little bit. But certainly the initiative of patients over paperwork is very important. She also talked about the program integrity focus area. Excuse me. And one of the things that she shared was that in 2017, there was over $15.5 billion on their return on investment, or the investigations and things that they had in place. So that was a $12 ROI, if you will, on the $1 investment that they made in their program integrity focus areas. So I think we all know in the compliance world that the oversight and the scrutiny by whether or not it's CMS or OIG is certainly high on the minds of our government friends. On this particular slide, we talk about expect more, pay less, shorten stays, and become more efficient, and really that patient-centered focus. I look at my notes from the OIG presentation, and I have 4 bullets here in my notes where it says OIG's desired outcomes: healthier people, lower cost, better care, more efficient system. So we put this slide together before we came to managed care, and I think whether it says CMS or OIG on this particular slide, I think we're hearing that message consistently, that we need our patients to be the center of the focus. CMS says, all of their initiatives right now are patients over paperwork, really making sure that our healthcare professionals have more time at the bedside, less time documenting. And then again, our OIG friends are talking to us about more efficient processes. So let's look at just 2 quick examples of new reimbursement models. In the post-acute world, which is where I grew up, if you will, these are near and dear to my heart. We have, on the skilled nursing facility side, our new patient-driven payment model. It's a brand new reimbursement model that went into effect in October. So all of our friends from the post-acute world, or from the skilled nursing facility world that are on this call right now, I think you're already well into that first quarter of seeing the changes that have come into place and the changes that it made in the organization. It's absolutely focused on patients versus volume of services. The previous reimbursement model really focused on a RUGs utilization that was more about therapy and some skilled services. Now it's really way more about the patient and the skilled services. So a completely different model. And then our friends in the home health space, they have PDGM as opposed to PM, so it's patient-driven groupings model. And this one is looking at clinical characteristics, again, versus therapy services. So another new reimbursement model that went into effect for home health in January. So just two examples of very current and recent changes that I know are affecting all of our friends, and certainly I'm sure have changed the compliance programs in your organization. And so as you're looking at 2020, I'm sure you're already looking at how do I incorporate these changes into my compliance plan, into my compliance program. So I'm going to turn it over to Mike, and we're going to talk a little bit about some new rules and regulations.
Absolutely. So thank you, Donna. Yesterday, as Donna mentioned, and over the weekend, we were around some of the OIG and CMS leaders who were updating those on the managed care side of healthcare. But really, as Donna just described, they really related similarly to the non-healthcare plan sector. The important thing that was stressed was a pair of proposed rules that were released both by HHS, OIG, and CMS in coordination to try to increase the utilization of value-based arrangements to drive healthcare outcomes and ease the regulatory burdens associated with patient care coordination. Now, after we all stopped chuckling when they said that they're there, the government, and they're there to help, they really do believe and are hoping and sought comment over the last couple of months of 2019 from providers on how their burdens could be reduced to try to eliminate the regulatory nuances as well as impact in your organization. They truly do mean and believe and hope that what they're about to release will do so. These will in turn affect the anti-kickback statute, the patient referral prohibition called SARC law, and in some cases, civil monetary penalties, which they would like to try to have you worry less about, yet increase the efficiency in patient care coordination. So we have a couple of slides for you here. The SARC law in particular is one of those, and we won't spend a bunch of time on it, but in this case, they sought and received several hundred comments that they have attempted to respond. They've responded to 80% of them so far, and hope that their new regulations will create some safe harbors and some ability to give some clarity in this regard. So you see some bullet points here. The public comment period has ended recently, and they do propose to have the new rules out in 2020. You can read more about them in the hypertext link on slide 14 about what that impact may be to your organization. On the next slide, with regard to the OIG's attempt to create some safe harbor updates, as well as to reflect what those civil monetary penalty fines would either be or to clarify them, this is more geared toward the kickback statute. And this is to help their goal, as Donna mentioned earlier, to promote coordinated patient care and improve the quality. Everything they talked about, any of the regulators yesterday at the conference really do hope and it will affect the patient care and quality. There were discussions from the, just so you know, the health plan market on New Mexico. There was a big article that they just released recently about how New Mexico has 70% of its beneficiaries that live in what would be considered very rural areas with not access to many of the caregivers that are needed and specialties, and how to challenge and induce as well as help alleviate the paperwork to get that care to that group. So they really do care. In fact, Kimberly Brandt was mentioning that her mom herself is in Medicare and that she has a niece, I believe, who has special needs and is disabled. And so they know personally what it's like to get approval for their own family members and use those as examples to say, we are just creating too many burdens here. How can we help these providers out? So they'd be based on value-based arrangements, patient engagement, and the outcomes that are delivered from it. Also noted on slide 15, there was some discussion on the cybersecurity side of things, with telehealth being the reasons and the desire for your health record to follow you anywhere you go through electronic records. They truly want this world very shortly to embrace and be a very transparent model to where if you are traveling with your parents or grandparents and something happens to them, that it is not difficult for that provider to get their notes, get caught up, and be able to provide care. So on slide 16, there was the final CMS proposed rules for enrollment. They are very concerned, continue and remain to be focusing on keeping the bad actors out. They're finding that people are being excluded in one state by Medicaid, moving to another, that one not talking to the other state and enrolling them and finding out later that was a prohibitive offense. They're talking about ways beyond just exclusions, but in all points of care that the enrolled providers are the good actors and not the bad actors. And so there are some proposed changes you can read at their announcement link at the bottom here, especially with regard to affiliates. And I would suggest it's a whole other webinar and another topic, which we have plenty of resources on our website. But the first tier downstream providers, if they are a part of your network in providing services, are high on the minds of the regulators. They don't want you just saying, we don't literally provide that service, we contract for it, and we don't really know anything about that provider, but we're not liable. They're going to hold you liable for your downstream vendors, and they want you knowing who you're doing business with. So you can look through the details. We should be hearing in the next 90 to 120 days on these safe harbors that are provided. With keeping our time in mind, I'm going to move to patient safety standards and controls. We thought this was very relevant to the discussion that Kimberly Brandt from CMS provided. The patient care, the quality of it, and the access to it. And what's really, what I think it's very easy to forget that, with all the regulations and requirements and things that you're having to focus, that you're actually providing care, good quality care to people. But who really is affected more often than not by bad actors? And the Johns Hopkins Bloomberg study is quite fascinating, talking about those vulnerable patient populations, and unfortunately, disproportionately, how minorities, disabled, and those duly enrolled are those most impacted by bad actors. There was a 4-year study concluded by Johns Hopkins on over 1 million Medicare beneficiaries treated by providers that they considered, for various reasons, quality of care, provider eligibility, to be jeopardized and affecting that many individuals. We thought of interest to you would be that of the excluded providers that were allowed to provide services in that population, they treated over 1.2 million beneficiaries during the study period of just 4 years. And those providers who, by definition, should not be in the federal healthcare program reimbursement because they're excluded, were actually paid $634 million. Those are dollars you have to chase back, or dollars you're going to have to pay a civil monetary fine for providing those excluded providers in your population. So these are real impactful numbers. And unfortunately, as you'll read in the study, minorities and those who are disabled receive the most care by that population. So we did heard quite a bit about opioid prescribing, its continuous problem, but good news, it is being severely impacted for the better by a lot of the OIG and coordinated care enforcement. So these strike forces that combine Medicaid, Medicare, OIG, DEA, they're actually working together, and it's paying off, and they're going after the docs that are the overprescribers, and they're catching them red-handed. This is one that we thought was relevant and interesting regarding a doctor who actually practiced here in Tennessee, but left to go to Indiana to try to get ahead of his problems. It caught up to him. His license was suspended due to 5 overdose deaths so far that they could attribute in just 1 year. You can see what happened to this individual and how he tried to stay ahead of it by moving to another state. there was a huge, two big opioid cases this past year in which I think they found over 600 providers involved from the medical practice. And they just recently, yesterday, announced against one of the pharmaceutical manufacturers a very large fine of them regarding kickbacks, and a very interesting scheme that they tried to put together to in the EHR medical record that would automatically prescribe a higher dose of medication than was needed, or even potentially even lethal to the individual, and that the coding intentionally done by the EMR company was designed to actually code at a higher level to get a higher reimbursement. And this jeopardized patients who were receiving high doses of medicine they shouldn't, just so that the pharmacy or pharmaceutical company could get a higher reimbursement. It's just terrible what's out there, and the OIG is literally throwing everything they have at it to stop this from happening. On slide 20, we wanted to tell you a little bit about the provider transparency that we think will be important for you to be thinking about in your 2020 planning. Patients now have more resources to discover information on who's providing the care. They can go on websites and do research about the provider. They can look inside networks and get grades, health grades on that individual. They're more educated, and the goal of HHS is to allow more information to be transparent to them. The value that creates is that the providers now are being both monitored, and there are patient satisfaction surveys about how satisfied the care was. That's going to drive your reimbursement, and it's going to drive referrals to those better actors than those who are actually not performing service at the level they should. There was a Milwaukee article that the Milwaukee Journal Sentinel and USA Today picked up that I think you might find of interest, not just because Donna lives there, but because it found that more than 250 doctors who had surrendered their license were still practicing, but in another state. This is just an example looking at a particular region. It's reflective of probably what's happening across the country. And that voluntarily surrendering your license can mean the public gets no access to information about what actually happened because they're trying to sweep that information under the rug. So how are you doing as an organization? What do you think you could do better to help make the transparency better for the patient safety by the diligence you do on enrolling and credentialing, but also knowing who your providers are? And that ties in obviously with patient data and technology. As we mentioned, the goal of HHS is to have records be transparent and transferable wherever you are, and easily accessible when you need the care. And that's going to take coordination by technology, by companies, by providers, by pharmacies, all working together to share the data in a secure environment that will make coordinated care. This will give more choices, better efficient models, but you have to focus on the security. They will give you no leniency if you are not putting into place the types of measures that would protect this data, and you would otherwise expose patient data to the marketplace for violations of HIPAA and everything else. So focus on your training. Make sure you have thought through your models and modules and who you're doing business with downstream, that they don't end up bringing you into problems because of their poor coordination. Donna?
All right, so as we get into our last section, we're going to talk a little bit more of some specific examples and perhaps how we can get started on a few things in 2020. So as we go into managing data and key metrics, the very next slide talks about metrics are only numbers unless they can tell a story that helps lead to actions. And I think we have said that in all the years now that I've been at Provider Trust and in my previous world, right? Numbers, data is just data until it tells a story. And unless you can put the pieces of information, the data together to ask questions and get information, they're really not that helpful. So I think as we go on and talk about metrics, and you think about what you're looking at in your compliance committee or in your your day-to-day, if you're lucky enough to have a dashboard for your organization, ask yourself if when I'm looking at these metrics or these numbers, is it telling me a story? Does it give me enough information that I can take the next step? Do you have a dashboard that lets you do that? Are you linking pieces of data together so that if I'm looking at returns to hospital, am I looking at the number of falls? Am I looking at staffing patterns? Like, what are those metrics that can come together on a dashboard that help me tell a story? And are we sharing those metrics, right? Are you communicating to other departments, or are you having all of the departments bringing the right pieces of data or metrics into your compliance committee so that they can be asking thoughtful questions and you can stay on top of it? Are you really able to actually allocate and identify resources so that when you do see a risk that you can look at process improvement? And then again, who are you communicating with, right? Who's hearing that story? As you're starting to identify risks or concerns in your metrics, are you sharing them with the right folks in other departments? Are you raising them to the leadership team? How are you using that, all of the data that we, I think generally speaking, feel inundated? There's just so much information, we don't know how to do it. So really start thinking about how you compartmentalize it and how you tell that story. This next slide is just a couple of samples, and I'm sure all of you have things like this and better ones, different ones, but we just put a few together. On the human resources side, certainly we all know that staffing is probably the #1 challenge for those of us in the healthcare space, really making sure you have sufficient staff, and as Mike has just been talking about, that you have the right people taking care of your patients. Hotline calls may or may not be in your HR or compliance team. Certainly turnover rates, agency utilization back in my life, we had a lot of staffing agency that we were using. So really monitoring that. Quality is certainly of high importance, as we've been talking about. We have quality measures that you might be looking at, medication errors, incidents, returned readmissions or return to hospitals, those sorts of things. 60-day overpayments when you're looking at your finance, or billing errors. And then in relationship, I added last night the vendor audits to the bottom of these 3 bullets. And I did that because I heard over and over in the sessions this week the importance and the expectations that CMS is putting on. Certainly at this conference, it was our health plans, but those of us at the hospital level or other levels of, are you really asking your vendor partners? You have contracts, but are you asking them and doing security questionnaires? Are you asking and having them provide you with evidence of exclusion monitoring that they're doing of their employees? So I just thought that was a highlight for me coming back, that certainly we all know we have to do it, but now they're really asking for evidence. So we'll go quickly through these last couple of slides. So again, when you talk about, am I ready for 2020, kind of building off of what we just talked about, how are you collaborating? Are you communicating across your departments? Do you monitor metrics across the organization or just within your silo? Are you able to tell a story? And then are you looking at compliance processes? I'm going to go through one super quick in just a couple of slides that I thought was just a really easy one to pick apart, because are you doing the same process that you've done for 5 years? And are you really looking at it to see, is it giving me the information that I need, or am I doing this process the same way because that's how I've always done it? So how do we plan for collaboration in 2020? I think it's really important. Something that we're doing at Provider Trust that has been really interesting in Q4 and now into 2020 is really defining accountabilities, making sure that each one of us understands what our role is and what we're responsible for, and being able to share that across the organization so people know who to talk to when they have information to share or a concern. Looking at overlap and duplicity. If you and I are both responsible for the same thing, who's really accountable for it and who's on the hook for it? So I think really making sure that as we have less and less staff, making sure that we don't spend time both doing the same thing or maybe doing it in different ways, and being as efficient as possible. Really looking at your risk areas, and should I monitor it, or is it a low risk? Should I just have metrics that I'm looking at, or do I need to do an audit, or do I need to go out and monitor something? And then certainly looking at the cadence of communication. How frequently do we need to be talking? How frequently do we need to be looking at this information? Some things are daily, maybe you have stand-ups. Some things are weekly or maybe monthly. And like I said, let's just pick a process and figure out who owns it. When's the last time I looked at it? Do we need to update education or communication? Am I really actually looking at risks that are or am I looking at metrics that are associated with the right risks? Are there risks that need new auditing this year? And how do I even know if the auditing that I'm doing is effective and that the corrective actions are working? So this is the example I wanted to use as far as picking a process. Obviously, at Provider Trust, employee monitoring is near and dear to our heart. So something that I would say that we are subject matter experts on. So one of the things that I would start with is who owns employee monitoring? And when I say employee monitoring, is it exclusions? Is it licenses? Is it sanctions? Is it shared between compliance and HR? Is it siloed? If I'm in compliance and I'm doing exclusion monitoring and my friends in HR are doing licenses and sanctions, are we talking to each other? We know that there's both parties have to be involved if there's a quote hit, if someone has an expired license or there's an exclusion. So making sure that we're clear on who's doing what and how we're sharing that information. How often am I screening providers, employees, third parties? How am I doing that? How often am I doing it? Am I doing it once a month? Am I only doing it upon hire and then at the time the license expires? My third parties, like my vendors, how am I getting that information? Am I monitoring it monthly? How frequently am I updating the vendor content? Like how many new vendors am I adding? All of those things are super important to really make sure that you're clear on, especially in the compliance department. How accurate is your provider credential information? I can tell you from firsthand experience that we find a lot of situations where we have employees whose names have changed and we've never really checked to see that the actual license information has changed with that name change. And so are you really monitoring the right person? How do you know if someone moves from one state to another? We know that many of our states have compact licenses for our nursing folks who can go from state to state, but are you tracking that? And when a person changes their address, have you looked to make sure that there's not an impact to their state license? And again, how are we communicating across the teams when we do find an issue? Are we talking to operations? Are we talking to the scheduling folks to make sure that they know that there's a concern? Who's investigating or mitigating these issues once they happen? And so often, are there regular cross-functional meetings about the employee monitoring best practices? So with that, we'll wrap it up with our get started. So update your process to look at your risks, right? Make sure you're looking at the right risks. Certainly facilitate open communication, collaboration. You want to be a leader, lead with example, be that person that's soliciting feedback from others and sharing information. Confirm you have the right metrics. We didn't really have time to dive into this, but I would challenge you to look at your risk assessment and look at your metrics that you're monitoring. Are you really monitoring the things that are affiliated to your high risk areas? Or do you have the same dashboard that you had last year? Again, does your dashboard tell you a story? Are you able to discern that there's areas of concern? Make sure that you're sharing cross-department, cross-committees, and then don't hesitate to reevaluate throughout the year and update as you need. Our world changes. We have all these new reimbursements. We talked about the regulations. Kim Brandt said she thinks by September they'll be issuing final rules and there'll be new regulations. I can't even remember the number that she said for this year, but it is a big number. It never, that's never going to stop. So you can't stop really reevaluating and looking at information throughout the year. So we went over a couple of minutes. Sorry, Matt. Hopefully that was some good content for you all. We will look forward to talking with you in February. I'll turn it over to Matt.
Great, thanks Donna and Mike, and thank you to you guys for all being here. Your time is valuable, and we so appreciate you choosing to spend that with us. We are here to help, so please do check out our resource page. Again, we will be we'll be sending out an email this afternoon with a recording of this webinar and a copy of the slides for you to have and share with whoever you think would value it. So with that, I just want to say thanks again from Provider Trust. I hope you all have a great rest of the week, and we will see you all in February.